And I'll say your patient is getting regular insulin and not or night insulin or whatever the order may be, and I'll have you pull up your insulin. But I'm not as concerned about pulling up the small vials of insulin as I am trying to get you ready to use the insulin pen, because the insulin pen is ideal. It's generally, I would say 80% of the time is what you're going to use in clinical, and it just works so much better. So orders the sliding scale, you would get a blood glucose check, you would verify the order in your MAR, and in Epic on your on your MAR, you're going to see a sliding scale. It's going to say, let's say the blood glucose was 224, you're going to give 4 units of insulin. It's going to tell you you're giving, 10 units of Lispro insulin with each meal. But in addition to that, you're going to go off your sliding scale. So if the blood glucose was 224, you're giving 10, you're going to end up with an additional 4 units. That's how it works. And one of the orders is kind of unclear when you look at it first in the lab, but we'll go over it and we'll make sure that you understand the amount that you're giving and why you're giving it. Sometimes there'll just be a straight 2 units of insulin ordered, and the blood glucose doesn't, this coverage, it's less than 160, so there's no extra coverage, but you are still going to be giving the ordered dose. So we go over that in the lab and we talk about it, let you get your hands on it. Insulin injection sites, and now that you've got your syringe, where do you inject it? See, like I was saying, the patients generally use this area. They use the abdomen because they're just sitting there. They give themselves a shot, and or they give it in the leg if they're wearing a dress or shorts or they're in their pajamas or whatever. But I feel like we can give those areas a respite and say, if you don't mind, I'll do it in your arm. Some patients will say, no, I don't like it in my arm. I have over the years noticed that insulin dependent diabetics are definitely, excuse me, very clear on what they want. It does say evidence based practice is good to rotate sites. Why? And I would say just for even distribution, scarring tissue, giving that spot a rest. In the hospital, we always use gloves and alcohol. Patients don't use gloves and alcohol in their homes. They generally will just give themselves a shot and move on with their day. I've seen that in the home setting, and whoa, what are you doing? Where's your alcohol? Where are your gloves? They're in their own environment. They don't feel the need for that. So these are just areas that you can get used to looking. This is the front, and they do this area, they rotate it, and you can kind of see the spots that are usually overused. The insulin pumps are something
Linda,
that,
we can't see your screen.
uh-oh, shoot. Now,
Yeah, now we can.
seeing the areas that they can overuse here in the front, their legs and arms, because it's easy access. And the back of the arms and the subcutaneous tissue are something that you have easy access to. So you're able to go ahead, get started, look at that, and give your injection. Like I said, some people say, no, don't do it there. My stomach feels better. I'm just used to it there. And maybe they don't understand that, that isn't probably the best practice, but we're going to try to accommodate the patients. The insulin pumps that are used are really, I mean, some of them malfunction, don't get me wrong. They do malfunction. Sometimes they, deliver too much insulin. They don't deliver enough insulin. They can cause some problems, but for the most part, they have really helped diabetics live a much more normal, stable lifestyle, in society. Diabetes is a hard thing to have. It's not, it's not easy for kids. Kids often have nurses that follow them around at school, but, the supply and demand isn't always there, so nurses can't do that. And my niece wasn't happy with that, so she pulled her little one out, and she's homeschooled her ever since, and open to school. So I feel like in some aspects it's good, but she's not got kids her age. She's got a younger clientele that she has at her little school, but it's just, you do the best you can. And I feel like this kind of a condition for a family is something that this kind of condition for a family is something that you definitely would have to grow acclimated to. You can't just step into it like that. It's really it's a hard thing for any family. And, you know, these pumps are used widely. The sub-Q needle that needs to be changed every 3 days, that's not so bad when a patient's getting 4 shots a day. I mean, this sub-Q needle changed every 3 days, that's a lot. That's a big difference, right? Patient can adjust the bolus dose based on their levels. And the pump, if it's is no electronic device is ever foolproof, but these have really come a long way. They're connected to your phone. For children, they're oftentimes connected to their parents' phone or their caregiver's phone, and everybody is on the same page. If somebody's going low, it it's something that can most definitely be addressed and looked at. It's really a really interesting thing. We had in one of our nurses had a son that was on an insulin pump, type 1 diabetic, and she was so involved in his care. She was so connected to this child's I don't know if it was a nurse, it might have been a nurse, it's their caregiver at school, their assistant at school, and they were all on the same page. She was always, oh, I've got to go make a call. And she'd say, you know what, call the assistant, are you checking him, where is he, because his sugar is going too high, it's going too low. I felt like, you know, that was a really good reason to jump out of class and go take care of that. And being a parent with a child like this, or even being a teen or a young adult with a situation like this, it's a lot of responsibility. But it does allow this population to be more flexible, to be more inclusive, to be able to be part of the student body that they go to school with, all of these things. I don't know if anybody's worked with an insulin pump. If anybody has anything to offer or share, let me know. Anybody? We can talk again in lab and share that information too, but these are the ideal things, I think, for the diabetic. It is so easy to set the device. I'm not saying they're not foolproof. They can, I guess, malfunction as well, but for the most part, I've never seen one malfunction. I've seen students give these injections. I've seen them trigger their pen before giving it and having to start all over. That's okay. We're learning. And once you get this skill down, it is really something that will not only assist you, but it'll assist your client, the person that you're taking care of, because it's a very precise measured dose. It's a very easy form of administration. And I like to think that we've come a huge way in this condition for these patients, because diabetes is no easy thing to live with. It just isn't. The repercussions from that a diabetic have to live with are really quite tough. They're a lot. They're a lot. Diabetes affects every single system in the body, and if there's non-compliance, there's always an ill effect. So we get these pens, we wash our hands, we put our gloves on, we clean the port, we screw on the little needle. I wonder if I have one here. No, I just have the vials. We screw on the needle, we prime it with 2 units of insulin. Patients at home say, I don't prime it. I'm not priming it. The first time I give it to myself with the pen, I want to make sure that I don't waste any. Well, you should prime it because you're just getting air. There's a little bit of air in that needle. I kind of think that the amount that squirts out might be wasting a little bit, but it always says to prime with 2 units of insulin, so that's what we do. One thing I can tell you with the patients in the hospital is, if your patient has an insulin pen, super important when they're being discharged to let them go home with that pen. Because what happens with that pen that's in the WOW is it goes back to the pharmacy and it gets wasted. Nobody's going to use another person's pen, even though there's no contamination at all. It doesn't get used again. And if you've heard anything in the last few years about pharma, big farm and all that, and how expensive insulin is, why waste it? It's been distributed to this particular patient. It's got their name on it. And as a student, no, we can't just say, here, take your pen home with you. But as a nurse, we certainly can. So remind your nurse to let that patient take their insulin pen home with them. It's got the cartridge. It says how many doses there are. You give, you can click to the amount. Let me see if there's a better picture. Oh, she is super dry, but we are going to listen to her. She does show you how to use the pen. Let me just make sure that you can hear her. Hold on. Please tell me if you can hear her. No? Jeez. Why is it doing that? Oh no, we don't want that. It's not working. Just a second. Let me just try one thing. You might have to listen to this on your own. I think because I shut all that stuff off when that lady wouldn't stop, it's not letting me go back into it. I need technical assistance here. All right, let's see if that works. Can you hear her? For Sarah, the certified educated diabetes educator is not working.
To share your screen first before we can hear her?
No, I have this. Okay, hold on. Here we go. Shoot, it just came up. Now? No?
Maybe try sharing your screen.
Yeah, we did the share screen here. Share.
And then push play.
Yeah, there we go. Now I did the
which would be the insulin
Now we
pen
can hear it.
itself,
That's
an
right.
alcohol swab, and the
All
pen
right.
needle.
Let's go back and give
And you
her
wanna
her
wa-
due. She's really.
My name is Sarah. I'm a certified diabetes educator. Today I'm going to demonstrate how to give insulin using an insulin pen. First you need to gather your supplies, which would be the insulin pen itself, an alcohol swab, and the pen needle.
And gloves.
Then you want to wash your hands with soap and water or use an alcohol sanitation solution.
Oh, nice nail.
Rub your hands together until it's dry. Start by removing the cap to the pen. At this point, if you have cloudy insulin, which would include NPH insulin or a mixture thereof, you want to mix it. You mix it with your palms, like rolling it together, or you can go gently back and forth. You don't want to rigorously shake it. If you have clear insulin that does not contain NPH, then you don't have to mix. You can skip that part altogether.
I'm going to pause it for 1 second. If you don't have a med tray, see me in lab. Go to the lab before. Oh, that's a cute dog. Look at that cute dog. Go to the lab before you go to clinical and make sure you have a med tray. Do not go to clinical without your med tray. That was a huge point in our meeting on Friday, that some students say they've never used one. You need one. You especially need one in semester 3. You have insulin. You have gloves to put on that tray. You have meds to put on that tray. You have IV pushes and vials to put on that tray. I don't want you trying to juggle all this. They go on a tray. It's neat, it's clean, and you don't forget steps. So don't forget your med tray. I have some in my office. If you need some, I'm happy to share. I have some in our lab cabinet too.
Use your alcohol wipe to wipe the rubber membrane on the end of the pen. And then remove the protective tab on the pen needle. Push the needle into the end of the pen and turn it clockwise to tighten it. Next, you want to do what we call a safety check to make sure there's no air in the system. You'll dial the dose indicator to 2 units, remove the outer needle cap and save that for later. The inner needle cap you can remove and throw away. So you've dialed to 2 units. You're going to push on the injector button and watch the end of the needle to make sure that you see some insulin come out. It might be a stream or it might be just drops of insulin.
Okay, so really quick, she's doing that, but the way she's doing it, that little drop of insulin will pull down in the area of the hub, and you don't want that. So you want to go down and watch it come out. That means that you've primed your needle. Your needle does not have any air in it any longer. It's ready to be administered after you dial the amount that you're giving. But in priming the needle, that just means like you're priming IV tubing, like you're priming an injectable that you're giving. You want to make sure that you've primed the needle so that that needle, you're not injecting any air and the patient's getting the correct amount of insulin. But don't go upward, because then when you go to give the injection and you count 6 seconds after you've inserted, 1, 2, 3, 4, 5, 6, which seems like 6 years. When you pull it out, you don't want to see a big puddle around that, and that's what can happen when you do prime it the way she's priming it. So that's just a little pointer.
As long as you see liquid there, you know that there's no air in the system.
Probably not.
Next, you're going to dial the dose that's been prescribed for you. For example, if 5 units is my dose, I'll dial to the mark right between the 4 and the 6. Then I'm ready to give it. The preferred site for insulin administration is the abdomen. The abdomen is from your rib cage to your hips and as far laterally as you can comfortably reach. You want to rotate sites so that you're not returning to the same couple places again and again. You should be about 2 finger widths away from your belly button. So first expose the injection site. Hold your pen like a writing pen or a dart, and then you want to go straight into the skin.
Now she's teaching an actual patient to do it to themselves, so that's really good information.
You can use the other hand if you wish, or the same hand, to push on the injector button, and you'll feel it and see it rotate as it's injected. And then once you've injected the entire solution, hold it for 10 seconds or count to 10 before removing the needle.
She just gave herself insulin right in front of us, didn't she?
When you're done, you want to dispose of that pen needle in a puncture-proof container. A coffee can, a detergent bottle, a prescription bottle, something that's puncture-proof and has a lid. You'll put the protective cap on and turn counterclockwise to remove the needle.
Do we use the scoop method there, or is that okay?
Lastly, you want to make sure the pen cap gets back on to protect.
Okay,
And
so
I noticed
there's a couple of things. She's teaching to an actual client. For us, once we give that injectable and you're done, the needle goes back in. There's a safety on our needles. We don't ever see the guard comes right back out. You remove that and throw it away. What's happened in my Oh gosh, so awful. The poor student put the blue cap right back on and dumped the whole thing in the sharps. So we lost a whole insulin pen. That's happened 2 or 3 times over my time as an instructor. And that is something that we don't want to do. We want to make sure that, hold on, we want to make sure that that doesn't happen, okay? You don't, once you get your hands on it, this is a little premature, but once you get your hands on it, you will be able to see how Bear had a perfect point. Now, how are we doing that? We do not cap needles. That's like the golden rule. We do not recap anything. Well, the needle, the extension needles that we use in the hospital and we use in the lab are the same. A little variations in some areas, but they have a safety on them. So as soon as you click, 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 hold it for 6 seconds, not 10, you pull it back out, the spring goes and covers that needle. So you never see the needle. You'll never see the needle. You push in with the spring, you pull out, the spring is tripped. And I'll let you have one, maybe two. I'll show you very closely how to do it so that you don't trip your needle before it's time. But it does work. We don't put you at risk for getting stuck by a diabetic's, insulin pen needle. And it really does work. Home glucose monitoring, it says key to maintaining control of glucose levels. It allows the patient to adjust their levels, immediate feedback, and the assessment of the blood glucose. The disadvantages is that it costs and knowledge deficits, complications related to denial. There are a lot of different little caveats that go to being a diabetic, that go to patients taking care of themselves. You may run into a patient that doesn't check their blood glucose every day because they don't want to waste their little sticks because these are expensive. Or their insurance doesn't pay for a lot of it, so they kind of space it out, thinking that it's better for them to save up these little, extra things that they use for their diabetes instead of maintaining it correctly. And that's sometimes where we as clinicians can come in and say, we have a discharge planner. There are resources that we can help you with. We have a diabetic educator that can pull resources as well. There's community resources that we can help you. SANSM has the diabetic research department where there are funds and there are ways to assist diabetics that need, extra lancets, extra, more insulin, that kind of stuff. People have died in our community because they've not had the insulin or the tools that they need to get, to monitor themselves. These different lab supplies are important for patients to have, and sometimes people cannot afford them. So there is a real need for that. Everyone will experience glucose testing this semester. It's usually ordered 30 minutes before a meal and at HS, depending on the physician. It says orders for testing usually include administering regular insulin citing scale. Always confirm with the MD if fast-acting insulin is to be given at hour of sleep, meaning that hour of sleep, you don't generally get food at that time. So why would we give fast-acting? Some do it because, excuse me, they're getting continuous TPN, which we'll talk about that too in the next couple of units. So when they're getting the TPN, which is the nutrition, that big white bag that you've seen that looks like a gigantic bag of milk, it's giving them insulin constant. It's giving them insulin constantly. It's giving them tons of sugar constantly. So you will be covering them with insulin. That's what I mean to say. Even though they're getting nothing by mouth, it is getting infused constantly. Type 2 diabetes. These are some of the types of medications that are given. On every unit that we discuss in semester 3, I pop up some slides that have medications on them so you can be aware. I mean, thiolidinidians, how hard is that to say? I like sulfonylureas is not so hard, but some of them are just so hard to say. Look at them, be aware of them. Meglitinides isn't that hard to say, but they're really ridiculously hard to say, and I understand that. But if you look at them and they spark your memory, that's the important thing, because you want to know what are these meds and what are they used for. This will help you in your weeklies. When you do your weeklies, you know that these are type 2 diabetic medications. Here's some more. It tells you what they are, some of their names, what to look for, their mechanism of action, timing, all of that stuff. Sulfonylureas, biguanides, meglitinides, those aren't as bad, but as you go further, they are kind of difficult to say. So there's just different medications that I'd like you to be aware of. I don't add them up here because put them up here so that you're going to be tested in your actual quizzes from them, but they will help you with your weeklies and your ATIs. So be sure to look them up. Take a moment. Take a moment to look them up so that they are in the back of your mind and they are part of what you're doing for your actual weeklies. It helps. It really does help. Goals for therapy for these diabetics. Obviously, you're going to have them for a day. Some of you guys will have them a couple of weeks in a row in clinical. That's happened to us many times because diabetics have problems. You look at that, prevent long-term complications at the end there. Our goal for therapy is to maintain their blood glucose while they're in your charge. That's our goal. You have the day to help them maintain their blood glucose. You have the day to do education. And if you've maintained a decent blood glucose throughout the day, you're golden. That's what you set out to do in your plan of care. That is a very, that is one of your goals for your plan of care. That is an excellent thing to set up for. My mission is to maintain blood glucose levels for my client during the day. And how am I going to do that? By correctly checking their blood glucose and making sure their meal choices are adequate, doing education, helping them with choices. Now, it says maintain a blood glucose. Make sure their foods are good choices. Make sure you've given your insulin on time. All of those things, you're solid, right? And then you go into the patient's room and they've got a box of See's candy open, some hot Cheetos, and a Pepsi sitting on their bedside table. God, I hate it when that happens. And you're just like, come on, man. I just got all this stuff set up for you. We're going so great. And you're going to go ahead and do that. They do that. And they're like, what? Oh, no, the doctor said that this was fine. Yeah, it's okay. A little bit. It helps me with my whatever. Or I haven't had anything to eat and their fingers are orange and their lips are red and their Pepsi is halfway finished. Sometimes we can't fix things, but that doesn't mean that we weren't doing our due diligence. Our part was met. We did the best we could. We started a plan of care, maintaining that blood glucose level for this brittle diabetic, and they're just blowing it. Oh, but one thing, when they have a counted carb diet, the dietary office is flagged, and they're like, I'll have that mac and cheese, I'll have a milkshake, why don't you give me a big bowl of fruit with a fruit parfait is good, and I'll have that apple crisp. And the person taking the orders gets a red flag as soon as they punch those things in. I'm sorry, you can get none of those things on this diet. Your doctor's ordered you X, Y, and Z, so that's where the student can step in and say, hey, I'm going to help you make some good choices. How about we order for your carb, the oatmeal, you can have a cup of tea with the sweetener, with the artificial sweetener. You can have sliced apples for your, there are ways to count those carbs that will assist that patient, okay? What they ordered and what you ordered are going to be two different things. If you're having a problem with them, you can always call our, the diet, what is it? Gosh, help me out here. What is our diet person in the dietary, our dietitian. You can always call the dietitian, and they're already aware of this patient being a diabetic. So yeah, sometimes their idea and your idea aren't the same. Sometimes your plan of care and their plan of care are not the same. You just got to work with them. We may not be able to save the world, but in our 12-hour shift, we're going to do our best to use that blood glucose as one of our main objectives, one of our ways to assist this patient to be at a level that they're supposed to be for our time that we're in charge of them. Um, Optimizing their serum lipids, that's what we're trying to do. The adequate calories, calories to gain and lose weight for optimal BMI, that's what we're trying to do when we help them with their choices and prevent these long-term complications. If your patient is in the hospital losing limbs, losing toes, losing heels, losing feet, losing legs because of diabetes, it's rough. It is really rough. It's hard on them. It's hard on you to watch. But if they are SWAT patients, it is super important to go in with your SWAT nurse. The SWAT nurses like to teach. They don't mind bringing you in. I want you to see what exactly you're working with, because oftentimes those are the dressings that you're not allowed to touch until SWAT gets there. And SWAT will come and tell the primary nurse, hey, I'm going to go and do a dressing change in this room. Or when you're in your bedside report, you hear, SWAT will be here this morning. Look out for them. You've only got 2 patients. And hopefully you're on top of it and you can go in and see what kind of long-term complications your patients have. It's scary sometimes to watch. I've seen pictures that I can't unsee. I've seen heels, foot. I had a diabetic patient as a new grad many years ago that was a brittle diabetic, which made her capillaries, her veins all compromised. And she had an MRI with contrast, or CT with contrast, meaning there was dye injected. And that dye burned her capillaries in her feet and hands. She didn't lose her fingers, but she lost half of her both feet. It fried those veins and capillaries in her feet, and she lost those. They had to be amputated. And that was so devastating for me, obviously for her, but for me, because I'd never taken care of anybody that had that actual kind of ill effect from dye that was injected. And she was already compromised, but that really was a big blow to her. Meal planning, we can help that diabetic make choices. Like I said, they're going to say, I'll have an apple crisp, mac and cheese. Give me a club sandwich, a Pepsi, and I'll have a bowl of ice cream. Wrong answer. They are individualized. Calorie goals should maintain a reasonable weight, 4 to 6 meals a day. Carbs, fat, protein should be eaten at consistent times each day. Choose carbs based on the glycemic index. And there are all those instructions in their chart, in their claims. You can get the sheets. You can pull up the sheets for them. You can go over good choices with them. That can also be part of your plan of care. Maintaining a good blood glucose, assisting patient with meal planning and education. Those are all things that are realistic that will help. I mean, I see things that students put down that they're never going to do and that aren't going to help that patient that day, but they look fantastic on paper. I don't want to see that if you're in my clinical group. I already know you're smart. All that stuff doesn't mean anything if it's not helping the patient. The glycemic index, you see high, low, and medium. All carbs are not created equal. Go through these things with your patients. Talk about, the low glycemic index foods, the eating carbs with protein that will help the slow absorption. And then foods that are higher in fiber also slow absorption. There's just ways to do it. Diabetic nutrition and alcohol. That is something that is so hard to get through a diabetic's head if they're drinkers. I know this on a personal level with a friend that he's a brittle diabetic since he was 18 years old and he's in his 60s. Alcohol consumption. It said alcohol can be consumed in moderation. Patients should count alcohol as carbohydrates. Never drink alcohol on an empty stomach. And then it says here, risks for hypoglycemia. It says alcohol decreases gluconeogenesis by the liver, and it decreases the release of the FFA, or the backup fuel. So thinking of this, there's a diabetic that I know that drinks an alcohol drink every evening or two and swears that it has nothing to do with his long-term A1Cs or his labs. Nothing. No, doctor says it's fine. Pretty sure it's not fine. Pretty sure if you got rid of the alcohol, your A1Cs would be better. you would be better overall, and your longevity, the fact that you've lived this long is so great, but you'd be even better without the alcohol. I'm not a real fan of alcohol. I don't mind it. You know, champagne is nice once in a while, but people that have this preconceived notion that alcohol and diabetes is okay and it works great, it really doesn't. It's not good for an alcoholic. And it says it can be consumed with moderation, but you know, once in a while, I guess it's not bad. I've heard, you know, some years back, oh, a glass of red wine is really good for cardiac patients. It really helps. And they go back and forth. Is it good? Is it not good? It just depends on the individual. But the alcohol is something that you can do in your teaching. There's also the education with the exercise that you can do. But the problem with this, oh gosh, it's not that time again. Give me 5 more minutes. The problem with this is not the fact that the diabetic has these exercise goals. The diabetic sometimes can't do these, okay? So it says treatment starts with the MD evaluation, improves strength and flexibility, it improves your emotional well-being, it decreases your body fat, it lowers your serum lipids, and also decreases the med amounts, yes, but if the diabetic has neuropathy already and has very sore feet, are they going to be able to do these walks every day? They're just going to sit and say, I can't. That's not going to be realistic for me. So I feel like sometimes the exercise goals for these poor diabetics, it's a double-edged sword. They're too obese, so they can't go exercise. They can't lose weight in exercise to reduce their weight. They're like stuck in the middle. So sometimes it helps to be a little creative. Like if they go to their doctor and the doctor says, you know, we've really got to assist you with some physical therapy. You need some physical therapy or you're going to lose it. You don't use it, you lose it. Your feet, your muscles, your muscle wasting, but you're gaining weight. What about pool therapy? Pool therapy can sometimes be an answer if they don't have a bunch of, you know, diabetic sores on their limbs and whatnot. There's just different things that are really hard to be so judgmental about. Exercise risks are also, you know, the younger diabetic, there's, you know, exercise risks to too much or too little. It can induce hypoglycemia. It can lower your blood sugar too fast. It says cardiac exacerbation. It can cause some unstable angina if, you know, the vascularities are compromised in these patients, or a new set of chest pain can cause a myocardial infarct. These are the kind of things that we look at. I'm going to have you take 10 again real quick, and then we're on our last bit of this. We're already on slide 40. We're on our last bit. We're going to take a break, but I do think what I'll say for you guys is we'll stay on this Zoom so you don't have to go back and forth. So the hypoglycemic diabetic induced by exercise, that means you're lowering your blood sugar. And it says can occur up to 24 hours after exercise. So the one thing to take into consideration is they need to test before, during, and after exercise. Prevention, eating protein and complex carbs before exercising, and eating their prescribed diet after workout. I mean, it's so hard on a diabetic because they're told one thing, but they're also told they need to exercise. They're also told, you know, they go back and forth. And I think keeping fit is important, but just working with these parameters really helps. And I do believe this before, during, and after exercise checking and eating is a test question. I'm good about telling you what I remember are test questions. I know our tests are changing this semester, but exercise risks can wear a diabetic bracelet, may need less insulin after a strenuous exercise because that body is pumping. Diabetic type 1 exercise every day at the same time is a good thing to do. Don't use exercise if glucose levels, do not exercise if the levels are greater than 240 and ketones are present. Do not exercise within an hour of the insulin injection. Measure glucose before, during, and after exercise. Don't inject insulin into the exercising body part, meaning if you're going to run, don't put the insulin in your thigh. Probably be better to do it in the back of your arm. And there are other precautions that you could recommend. What do you think those would be? I think recommending that they watch their diet, They eat about the same thing every day. Every time they've had an exercise regimen that worked out well, try to stick to similarities like that. That's an important thing. Complications, immediate and life-threatening. Hypo and hyperglycemic symptoms would be for the hypo, sweating, pallor, for the hyper, dry mouth, increased thirst, hypoglycemic irritability, hunger, lack of coordination, and sleepiness. These patients can get dizzy and act funny. Same thing on the other side of the coin, the hyperglycemia, weakness, headache, blurred vision, frequent urination. All of these things are things to make sure that your patient is aware of. These are just little keynotes. Cold and clammy, get some candy. That's one thing. Common symptoms of low blood sugar, would be trembling, having that pounding heart, sweating, feeling all of a sudden very hungry, numbness and tingling generally in the tip of their fingers where they don't feel very much anyway. They get sleepy, irritable, or even a headache all of a sudden. A very, very low blood sugar, I would say, is confusion, the blurred vision. They almost start to sound like they're stroking out on you, and then seizures and coma, of course. Quick acting, carbs, low fat milk, OJ. They may have to have, you don't need to see that for right now. They may have to have a injection of the glucagon. It just depends. It's really hard to, say whether these patients are able to get back to where they need to be with little assistance or they need a lot. So administer insulin and IV fluids for the hyper, monitor the glucose. Well, going back to the hypo, it is still monitoring the glucose, but enhancing or giving. You're giving, if they're awake and coherent enough to drink something, to drink the low fat milk or the orange juice, or take the candy in their mouth, something that they can absorb quickly, that kind of thing. It's all what works for this patient, and they generally will know, or you're going to have to be the one that helps them. Hot and dry, sugars high. So they get hot, blurry vision, excessive thirst. Their breath smells like a fruity smell that you'll never forget if you smell it. They get extra hungry, or they get very nauseous and start to vomit. That could mean, too little insulin, too much food, increased emotional stress or outside stress, infection, an acute illness, a big surgery, that could also happen. Now, this is one thing that I didn't want to stop today after we've talked so much about diabetes, is the chronic issues. And we do get into the chronic issues in part 2, but these are all the things that we study. We're going to talk about the kidneys. We have a neuro section. We have, brain, our neuro section, our cardiac section, the eyes and the extremities. All of these things are affected by diabetes, by non-compliance, and even the compliant. The compliant also can be that much affected in all of these areas. I mean, for the eyes, for example, it's very difficult when they have the retinal neuropathies. Their retinas aren't working correctly. They start to slow down. Their vision starts to decrease. High blood pressure, high blood glucose, and high blood pressure can damage these vessels. And the retinopathy, cataracts, and glaucoma step right in, cause vision impairment. Difficult. The kidneys, the high blood pressure damages the small vessels. Excess blood glucose overworks those kidneys and those renal arteries, meaning that it can be that insult on those renal arteries and they don't get it back. They have failure, and it's a consistent thing. Neuropathy damages the nervous system, so they have numbness in their feet, meaning that little skin tears or little wrinkles in their socks that cause, wounds can go undetected because they can't feel it, leading to gangrene, amputation, all of those things. For their brain, increased stroke, cerebral vascular disease, including TIAs or trans-ischemic attacks, cognitive impairment because their brains are not functioning at full capacity. The heart is a big one. Cardiac, congestive heart failure, coronary artery disease, myocardial infarcts. These are all coronary heart diseases that come secondary to being a diabetic. Peripheral vascular disease, the narrowing of those vessels, causing it difficult for that blood flow, and healing process gets slowed way down. Gangrene, peripheral artery disease, these things are all chronic issues, and chances are these are all the reasons you'll be taking care of these diabetic patients in the acute care setting. These are the reasons, and it's really sad that there wasn't enough education or there was too much incompliance. And the non-compliant patient is not the patient that maybe meant to be non-compliant. Maybe that's what I'm trying to say. Maybe they are the patients that didn't have the resources or had to put their own health aside to care for their families, which you got to put your own mask on first with the oxygen to help the next person aside you. And this is kind of what happens. So the nephropathy or the kidneys, what interventions could you expect for end-stage renal disease? Damage to those renal vessels can lead to the kidney failure. 1/3 of new end-stage renal patients are diabetic. Kidney failure is a whole nother animal that we're going to attack. It's really hard. It's really sad. And a lot of times it's not anything that they can do. The retinopathy, vessel occlusion causes retinal ischemia in the eyes, and having laser treatments and having injections and these kind of things kind of weighed off these problems, but they're more likely, 25 times more likely to become blind with diabetes mellitus. It is really something that is really difficult on these patients. It says, other than an annual eye exam, these patients usually get seen every 3 months or every month if they have to. They have, a lot of risk for blindness. The neuropathy, damage to the myelin sheath, and you see a normal sheath is all connected, it's got the vascularity, and then the diseased sheath, you see little breakdown in this area where the normal nerve is, and then nerves shrivel and disappear, causing them to have no feeling whatsoever. Burning, numbness, and tingling and pain, and the gabapentins are taken, the Lyricas are taken, but it doesn't correct the problem. It just helps with the symptoms. Oh yeah, that's really an amputation of a foot. That's something that you can't unsee. That is probably in a third world area, but you will see, honestly, in our homeless population, you will see problems. Maybe not this extreme, because we do have a pretty great community out there of public health, but you'll see non-healing ulcers causing necrosis, amputation, 60 to 80% of them get amputated. And then they have no feeling, poor circulation, blood glucose levels are through the roof, WBCs, their white blood cells, they've got infection at such a rate that they can't manage, and they don't know how to manage. Oftentimes the homeless population have also got a lot of mental illness, so this is not their priority. How to prevent it, and you see this is in the stages where they're already going to wound care. Oftentimes these patients that go to wound care live alone. They don't have the resources or the ability. Here it says how to prevent it, daily foot inspection. Sometimes they just can't, or their elderly spouse is unable to even bend over to see, or they can't see. There's so many things that fall into place here. I take care of those patients because in my little infusion suite at Goleta Valley, it's just me, and then the outpatient nurses back me up when I can't do it. The wound care center is there, and they come after wound care, so they'll get IV infusions after they've gone to the hyperbaric chambers, or they've gone to their wound care cleanup sessions with the nurses. And it says here, daily foot inspections, well-fitted, hard-soled shoes. Some of them don't walk. Break in shoes slowly. Do not walk barefooted. Cut their nails straight. Some of them don't even cut their nails. They can't even get to their feet because of the atrophy and their physicalities, all of those things. Keep their feet clean and dry. Sometimes they're, they may have some services. Maybe they get bathed twice a week or 3 times a week by outsourced, nursing care, but a lot of it is not realistic. It's really hard. Our mission that we chose to accept is to assist these patients while they're in our care. So we are going to do those in that foot care. We are going to look at these feet. We're going to check them out. We're going to go through and see what we can do to assist them, to give them the educational tools that they need. Or if sometimes it's beyond our scope, we can have the case managers assist them with further resources. And we do have in the hospital at all times a diabetic educator. Maybe not on night shift. I think from 19 to 07 we don't, but during the day we have a diabetic educator, a couple of them, and we can call them and say, this patient is not clear, this patient doesn't understand, or this patient needs a little more education. So there's that going on. We did see a few of these. Here's our little darling down here. I want you to listen to her today in the afternoon when you've got a moment, when you've had time to digest all this stuff that I've said. I'm not going to say let's take a 5 because I want to go right into our other class. So bear with me. I'm going to share the screen. We've done a lot today, but I do want to go through and get our Peds up on the same one so you don't have to go to the next class. I do understand you know how to do that, but it's easier for me to do this than it is for you. This is our Peds home screen with our little baby and mom and those cute little kids. Same thing with this with our screen. You have your weekly Zoom link right here. I will make sure that we check our link for MSIII because you weren't able to just pop right into it. And then I'm just going to go over here to our modules. It's pretty much like our MSIII class, so that's one thing. Our planner is the same. Our syllabus is a little different, okay? It can be very confusing for you because Mary and I have to share this class. We have to have one Canvas site for the whole class, but it is 2 classes, so here we are, okay? This is all our information. These are all our hours. These are all our classes. I'd like you to go through this. Let me make it a little bit bigger. It would help to go through this and see what our objectives are. My main objective for you to understand about pediatrics, it's different than maternal newborn, is that you are already acute care students. You know how to work in the acute care setting. Pediatrics is acute care. The specialty is the age group. So our objective as we start is to go through our objectives here on the syllabus. And again, our ATI is the same. You have a practice ATI. We're going to do the same scoring, the same way we do things that we do in MSIII, but we are also going to have, God, there's so much because it's 2 classes. There's our focused reviews. It's all going to be the same. It's going to be 20, 15, and we do have to still fix that. Our Peds is here. We have, again, this is one thing that is going to be a tiny bit adjusted. Mary and I are going to meet tomorrow and get everything fine-tuned because she will have it ready for you for your class on Thursday. Going back to our modules, we have the same planner, a Peds clinical log write-up that I want to talk to you about. This is a write-up that you're going to get your points for being in clinical. When you're in clinical, you're going to have one patient. You're either going to be in Peds, you're going to be in pediatric intensive care, or you're going to be in neonatal intensive care, those 3 areas. One of our clinical instructors has bowed out. He's not able to do this semester, so I'm going to have to pick up a little bit of slack and do some clinical and Peds. I've done Peds clinical for a lot of years, so it's not a problem for me. But it is something that I want you to be prepared for. You do a care plan, a time grid, all of the paperwork that you would do for a MSIII patient, you're going to do for your patient, and you're going to do a journal entry for each day that you're in clinical. So that would mean you have 3 clinical days for Peds. You're going to have 3 care plans. If you have more than one patient, one leaves and another one comes, you're going to have 2 care plans. You're still going to have one time grid, and you're going to have another for your next patient if you get another patient. You're going to have a journal entry. And the thing with the journal entry and the difference is Many of you have children, many of you do not. Many of you have worked with children, many of you have not. Some people really love the fact that they're going to Peds, and some people would rather have all their fingernails pulled out than take care of children. It goes both ways, but once you have the experience, I would like you to write about it. Some of the nurses are very welcoming. They're really nice. Some of them aren't, and I'm not going to try to sugarcoat it. A director there is not very nice all the time, but we've been working with her for, all these years, and she's not going away, so we have to learn to work with her, okay? Peds is a specialty area, so to speak, because you're taking care of patients that have different age groups and different requirements and qualities to their lives. And I go through that with you briefly today, but also I'm going to show you something in our planner here. So one care plan, one journal entry, and this is due after your last clinical day in Peds. You can't do all 3 of them until you're done with your Peds. The last day of your clinical, you have until midnight. So if you did 2 clinical days way over here in the beginning or whatever, how it's all mixed up and so crazy, that clinical schedule, and you do one at the very end, oh, can I have a week to do it? No, you can't. You have that day to finish it, and by midnight of your last clinical day, I want them turned in and uploaded. They don't take any time. You've already done your care plan in your clinical day, should be done. Your journal entry takes no more than 10 minutes. Please type it though. I've always said, yeah, write it on paper, it's fine, and upload it, but I can't read some of you guys' writing is bad. So I just say type it up. It doesn't have to be a big manifesto. I just want to know how your day went. From A to Z. How did it go? How did you like it? Did you love it? Did you hate it? Will you never have children now ever in your life? Or do you want a whole house full? It just depends on the person, themselves. So we go to that. That is what your clinical log write-up is due the midnight of the last day of your clinical day. And I will put that in writing. I have given, it's at your discretion, get it in, and people get it in the night before your final. I don't have time to grade all of those things. So in growth and development, we have, let me see, you guys can see my screen, right? There are a lot of slides that we're not going to have to finish today. We will be done by noon like we promised. But nursing care of children and families, these are your books. Those are your required readings. Really our skills, we're going to demonstrate our one little syringe pump in lab. We can do it the first day when we do the IV skills. It's just one pump that we use for smaller children because the doses are much more precise. It's super easy. It's super user-friendly. You can look at these 2 videos and see how you just set in the medication, and you will do it with your nurse the first time. It's not difficult at all. Our Peds nurse that was going to come to clinical and show you this actual setting is not able to do it yet, but we may be able to get him in before you guys start your rotation. It will be a guest person that will come on a Friday when we have lab. It just says our required skills to go in is giving oral medications with the syringe. The syringe for oral medication must be orange in color. You see here, this doesn't have any of the circular area where you can put a needle on it because it's only for the oral medications. That's important to remember. Those syringes are only for liquid medications. She's pretty cute, but we're not going to listen to her today. I want you to listen to her. Oh gosh, is it something about these are not letting me go to the next thing. I just want to show you your growth and development. We're going to go through all of these in our classes, and that is growth and development and general care of the hospitalized patient. But we have a guest speaker on Monday. It is Monday, right? Hang on, let me double check. Janie comes from the hospital, and she is the child life. She does the child life planning for all the children in the hospital. She goes to families all over. And here, let's see, she's our child life specialist. She comes on Monday, so a week from today. She'll be coming in from noon to 1, and you guys will be talking about her and then doing a brief write-up right after we're done with that. That is our day on Monday. But Janie gets you kind of prepared for the type of patients that you're going to be meeting and what to expect in the hospital. Can anybody put their hand up if they really aren't interested in this PEDS option and they're just like not looking forward to it? No. A few people are saying, yeah, heck to the no. I do not want to do this. These PEDS kids. Yep, there are a few. Okay, well, it is part of the program. We have to do it. It goes by very quickly. I do know that PEDS is okay. I don't usually get complaints. PEDS nurses can be a tiny bit rough. PI nurse, the intensive care, students really enjoy getting the education from those nurses because they are excellent, excellent teachers. They want to teach. They show you things that you never thought you'd ever be involved in. The problem right now in our climate is several of the patients will be COVID patients. We don't take care of COVID patients. We can be on the outside listening, but you don't get to generally take care of a COVID patient. If there are 0 patients on the unit, if they're slim pickings, you will get to follow a nurse that takes care of a COVID patient. You're just not going to get to actually do direct patient care with that patient because we don't want to put you at risk. We don't want to put the child at risk. There's a lot of different reasons, and we aren't fit tested, so we just aren't going to go there with that. But PI, they love to do a lot of good education, a lot of good teaching, and it's really a very good spot. And then the NICU is always, hands down, everybody's favorite. When you're done with this rotation, everybody wants to be a NICU nurse. They love the rotation. People are saying, no, no babies. They love working with those tiny infants that are at your mercy. We do have our theorists that we talk about, Piaget for cognitive, Erickson, and there's a little star there. You need to know Erickson. So look at this one. This is excellent narrative there. They do such good writing. He does such good pictures and explains it so well. Erickson's is a must-know for quiz, just so you know. Here are the child's hierarchy of needs, and it shows you self-actualization, esteem, social needs, safety and security, and the physiological needs. And I know you had to do that in psychology class, but this right here is going to be on one of your quizzes to write out. I can tell you that. You have to be able to know what you're talking about, like give an example perhaps, but it goes birth to 1, trust versus mistrust, ages 1 to 3, autonomy versus shame and doubt, 3 to 6, initiative versus guilt, 6 to 12, industry versus inferiority, 12 to 18, identity versus confusion, and you are all the young adults, intimacy versus isolation. So with that, we do go through each stage, but before I do that, I want to move ahead real quick. We're going to go through each section the next time we meet. Locomotion. These are all of the fine motor skills. I just want you to look through, and we go all the way through to the toddlers. We go through every stage, but I'm going to get out of here and show you exactly what I'm talking about for this. Oh, shoot. Hold on. This growth and development project is due before your first quiz because it will help you get what you need in your brain for each set of students that we just went over, set of patients, that we just went over. So here it says infant, birth to 12 months, toddler, 1 to 3 years. These are the age groups. A growth and development for a 3-year-old to a 6-year-old, age 6 to 12. Dang, my daughter has 1 in each group. I should bring my grandkids in. There's 1 in that group. There's 1 in that group. No, she's not quite 3, but she's got 1 in this group and 1 in this group and 1 on the way. She could do this assignment for all of us. How about that? I think I'll bring her in as a guest speaker. I watch those kids all the time. They're a lot. But this does help. It really does help. So this is what You will fill out each one of these sections. This one, you can actually do handwriting if your handwriting is neat. I don't want it cut and pasted because you don't learn it if you do it cut and paste. If you write everything out, I'm not kidding you. When you take your first quiz, you know everything. You can, you know, compartmentalize. You can put each group into their age group. You can know what their changes are, what their self-concept is. You go through all of that. It is a big project. I do not mind if you work together, but I don't want you to, okay, I got 5 in my group, you take that page, you take that page, we'll put them all together. You won't learn it that way. It will not benefit you. Then it will be nothing but busy work, and I don't want you to do busy work. This is actually a tool that will help you throughout the whole semester in pediatrics. You get to keep a hard copy of it. You can refer to it. It will help you in each unit. There's not a lot to cover in this unit. There really isn't. This is the main bulk of this because, again, they are acute care patients that you're going to be taking care of, but they have different needs because of what stage they are in life. And you're working with general adults when you're in the hospital. I understand that. But it is very important to know what these patients are experiencing. And again, having Janie come in and talk to you, getting you ready for peds, is a real big plus. We are going to do growth and development one more time. So let's see what this is. Week 1 and week 2 is, oh, you don't even have a lecture. Week 3, there's no, wait. Does Janie, hold on, hold the press. It says week 3, hold on. You're not getting a quiz week 3 without all of this. Hold on 1 second. You're going, wait, this is a tiny bit mixed up. We'll fix it, don't worry. Let's go back to our planner. I got you for 10 more minutes, so hold on. So week 1, it says here, we have our child life specialist. We will go through. I don't believe we'll need all of this for our second part of endocrine. I don't believe we will. And we'll start peds a little bit early. We'll finish this whole section. Hopefully you'll be looking at your growth and development assignment and filling things in as you can, and listen to Janie. And then yes, you will need to have it filled out this week. You have this week, but week 3, I took that quiz away and it's not here until week 4. So I do have to fix the home page. So look at this as your actual guide. You are going to have time to finish that project, and you need it before midnight on this date when you have the quiz, because that's when you'll use it. So don't freak out when I looked at that homepage. I will get that homepage fixed. But we will have time to get the content, to talk about these patients. It really does help to listen to Janie's aspect of things. She's done it for many years. She, in fact, is the only one in the hospital. And just in the last 2 years, she's got interns from UCSB that are training to become child life specialists. So there is a need for it in the hospital. She explains that so well. She's really passionate about what she does. Working with the patients in the hospital can be tricky. And one thing that, before I let you go and digest this long-winded day of mine, which I am very sorry, Mondays are a long-winded day. You have me all day, I get it. And labs are kind of rough, but you don't have me like every second in the lab. You're doing your own thing. Monday's a little more difficult. But with that being said, Janie helps you step into the clinical setting without being so apprehensive. She has tools, and what my point is, and I'll bring it back to every single area that we cover in class, is taking care of the entire family unit, not just that kid. Because sometimes those kids need you more than you'll ever know as their nurse for the day, but sometimes it's the parents that need you more so than anything. They need your help. They need your support. They just need somebody to lean their shoulder on, because they are generally tired, generally overworked. Sometimes these families have 3 other kids at home that they have to tend to, and this child is very sick in the hospital. So they look to the caregivers to say, hey, I need some help. Even if it's just, you know, Bear going into the room and saying, hey, I'm going to hold the baby while you go get some breakfast, lunch, while you go take a shower, or while you take a nap. How's that? That's something that can be monumental. Maybe that mother or father or caregiver hasn't had a shower in 3 days and that room stinks. You're like, yeah, I'm good. You need to go shower. I'll watch this baby for you. I'll watch this child for you. I'll sit and play checkers with this, paraplegic while you go do what you have to do. I'm here to help you. And you are taking care of the whole family unit. Maybe the kid's been screaming for 16 hours and finally went to sleep, and you say, oh, time grid says it's time for me to do my assessment. Wrong. Think about it. Think about the whole family unit. You tried to do assessment and wake up that kid. That parent is going to cut you. It's going to be bad. We don't want that. We want to work with the whole family unit. We are going to take care of the entire family unit. That is really important. And I know you're taught that in MSIII, and I will talk to you about the whole family unit as we get into each occurrence with MSIII. But this is also MSIII, and these little humans are more dependent on their caregivers usually than adults are. So that is a big thing to take into consideration. Peds is a specialty area again, but at the same time, it is also MSIII. Do I have questions on pediatrics from you guys? Because we're about wrapping it up. I know it was a quick intro to Peds, but next week we'll meet and you'll get a better block because I did want to finish that unit in endocrine. Anybody have questions for me? Come on, where's my question? My question, students.
Linda, I have a quick question as far as the schedule that's currently up. Were you going to do other adjustments? Because I wanted to print it.
Don't print it. Don't ever print it. Look at it weekly. That is something I can give you slight words of wisdom. Pull it up on your tablet and look at it on Sunday night every week.
Okay.
Don't print it because I have students who say, I didn't show up. My name was here. Here I showed up and I'm not supposed to be here and you got changed. That's one thing about accountability for this program. We actually, for the first time in the 16 and a half years that I've been here, we have a person who is designated to that clinical schedule. Some of you may have had her in clinical. Her name is Sierra. Darling gal. She is the point person. Don't bombard her. Just, Julia, pull up your schedule once a week on Sunday. If it's been changed drastically and you're like, hey, whoa, wait a second, I can't. It may just be that your instructor got changed or your floor got changed, not your day, but it could happen too. So please be aware that that schedule is not set in stone, as this one is not. I'm going to do, well, I want to see who's looking. Who's looking at January 23rd? Melody Barajas is looking. I want to make sure, wait, let me see who's looking. I think that's me. Anonymous, Manatee. I like that one too. I want to make sure that you guys are clear, very clear, because I don't want questions about these. If you ask me a question about something that I've said 50 times, I'm going to think, oh boy, we got a problem here. How are we going to fix this person? Because I'm going to say it and say it and say it. Look at your planner every single day of class. Something could change. But I will say this. I am going to IT on tomorrow at 10 o'clock in the morning, and I will make sure that what's on here on your homepage gets populated to the calendar so that you can look at a calendar. A lot of people use that calendar. I get it. I understand it. But we have to make sure that you use this first if any of those other things aren't working just perfectly. I do want to thank Bear for doing those recordings because the recordings don't ever work for me. 20, 21, 20. Yeah, a couple of years now, and they work 4 or 5 times and then they don't. And it's a big mess trying to retrieve. So I just said, you're welcome to record, any of you. I don't mind being recorded. I mean, I don't say anything that chilling or interesting, but I'm glad that you're able to record and listen to it again. What was I saying? Please, that was a good question, Julian. I'm glad you brought it up. Do not print it because you're going to be wasting paper and it's going to change every time. So far this week, it's not going to change. I think I am done by 12. Oh no, I'm letting you go by noon because my voice is failing. If you come to my meeting at 2 o'clock, it's SNA. It's a fun meeting. It's very brief. It's like half an hour at most. We just talk about our plans for the semester. You can start looking at your ATI adaptives. You can start looking at your growth and development chart. You can start looking at your insulin test. There's so much, tons of fun stuff to do. Do I have any questions from anybody else? Thank you, Julia, for that. Everybody seems pretty awake now. This morning, you guys were sleepy.
I have a question on the study guides that you said you would be giving us for MedSurg. When will you be?
They aren't study guides. I give you points in class. I give you verbal points in class. They aren't study guides. I'm not allowed to give you study guides.
Oh, okay,
I do
so-
give them for a midterm and for a final, but I will talk about what I think you should study. How's that?
Gotcha. Sure. Thanks.
I will talk about it. I will say, oh, you guys have a quiz on, let's see, when's our first one? Oh, you got two quiz. No, you got one quiz in the third week on endocrine. I will say this. How about, wait, did I change that? Huh. Yeah, week 3, that gives you plenty of time. I will say this. How about I would know all my insulins, I would know XYZ, and maybe a free response question will be, if I was a student, I can't even remember what the one is that I put this semester. How would I deliver insulin to a patient as a student? There's little different tricks, and it's not because I'm trying to be a bad, mean person. It's because that's what NCLEX is going to do to you. I have a whole list of new ways that they're going to ask you questions. So if I said, if you're the nurse administering insulin, what are the steps you would take? And then I would say, if you're the student administering insulin, what are the steps that you would take? Meaning that a student has a few more steps than the nurse has. Way back in the day when I was a student, you had to have 2 people signing off that insulin. Well, just in the last 2 years, that rule's changed. We don't have 2 nurses signing off on it. Students always have a nurse signing off on it. Students always have a clinical instructor signing off on it. And that, if that isn't in your narrative, you missed the question. I hope that makes sense to you, because that is a big one. If I ask you, what does a nurse do as opposed to what does a student do, there are going to be 2 different answers. And if you get that point down now, most of your free response questions are going to be golden. You're going to get all the points for them. And they're usually a lot of points. They're usually a lot of the points of your quiz. But who was the student that asked that question? That was Mahea. Mahea, I will not hand you a guide that says these are the things to study for quiz 1. There's 10 questions or 20 questions. I just tell you. And if you're engaged and in the course, I say, hey, if I were you, I'd study X, Y, and Z. I'd look at maybe 3 questions about this, 3 about that, 2 about that, and here's a free response question. I hook you up. I make sure that you kind of can focus for your quizzes on what you need to focus on. So that's something that you can trust me on. But a study guide, an actual physical study guide, that I won't give you. I may give you one for the midterms and the finals, but I don't even think I'm supposed to do that anymore, but I'm not sure. But I will give you those. Good question. Anybody else? You guys are all right. You guys are going to do well. And guess what? This semester is going to fly by like lightning. And you're going to be like, I can't believe it's summer. And I'm going to go sit in a swimming pool for like a month because that was so much. That was such a lot. But you're going to all get through it. You guys are all good students. So if you need me for anything else, hang back. If you don't want to ask questions while everybody's in, hang back. I'll be sitting here for a while. And then I'm going to get out and get ready for my student nurse meeting, which the link is on the announcements in your, let me show you where it is.